Hello, everybody. This is Natasha Helfer, and this is the Healing Souls podcast. I'm so excited to have Dr. Christine King Burke with me today. I've had really a super pleasurable experience listening to you talk on many occasions. You help out with the Bueller Institute with my colleague Stephanie Bueller. I help her teach sex therapy to professionals who are wanting to become sex therapists, and you usually come in about twice a year to help teach this piece about pelvic floor pain and sex, when sex hurts type of issue. So Christine is the clinical supervisor for the Hoag Pelvic Health Program in Newport Beach, California. And she specializes in pelvic health. She's got a background in orthopedics that she incorporates, and she treats patients with all kinds of issues. So hip pain, coccyx pain, painful intercourse, postpartum complications, interstitial cystitis, which we'll talk about because that's a big word.
Yes.
Pelvic pain, incontinence, etc. So anyway, welcome to the program. I'm thrilled to have you. Unfortunately, this is a common issue. Do you want to talk a little bit about, maybe I'm putting you on the spot with statistics, but it's really common, right? For women to say, I have a problem with sex hurting at some point in their lives.
Absolutely. Yeah. First of all, Natasha, thank you so much for having me. I'm super excited to be here with you today. But yeah, you hit the nail on the head. This is a very, very common problem for women for a variety of reasons that we'll delve into today. But painful intercourse, we always kind of want to delineate between what we always say in our practice. Painful intercourse is common, but it's not normal. So it's something that's very, very common. We do hear a lot of it in our practice, but it is something that you don't have to live with. There are treatments out there. There are ways that you can address it.
Okay, so point number one, sex is not supposed to hurt, right?
Correct. Yes. Very, very important point number one, just getting right into this here. But yeah, absolutely. Sex is meant to be a pleasurable experience and shouldn't be something that elicits pain. If it's eliciting pain, that is your body telling you that something is going on, and it is definitely something that, if it persists, it's something that you want to look into.
Right. And I think, just to get it out there, most women at some point of their lived experience have probably heard from another woman the pain is going to hurt at some level.
Oh, absolutely.
It's your mom or your aunt or your well-meaning friends. And I think there's even some myths around pain or sex is supposed to hurt the first time. So first time intercourse. So can we put a nix on all of that?
Absolutely. Yeah, I'm with you. There is definitely, a stigma out there that, sometimes sex hurts, and, we hear it all the time in our practice, after a baby, sex just hurts. As you age, sex just hurts, and sex should never just hurt. So yeah, I'm with you. We'll put a nix on it.
Okay, perfect. Because I think that's why a lot of women aren't seeking treatment, is that they're just expecting that this is supposed to be the way it is, and that they're supposed to put up with some level of discomfort.
Absolutely. Yeah, we're normalizing it and making it sound like, oh, well, this just happens sometimes, and that you just kind of deal with it.
Okay. So the fancy word for pain during sex is dyspareunia. Can you talk a little bit about that word and what it means, and what has to be part of the equation for you to get that quote unquote diagnosis?
Yeah, absolutely. So dyspareunia is its own diagnosis in the ICD-10. So dyspareunia, as you said, it's the fancy medical term for painful intercourse. So typically when we're talking about dyspareunia, what we're talking about is a female having pain upon vaginal penetration with vaginal penetrative intercourse. Men can have pain with sex as well. That has its own separate kind of diagnosis. It's called male dyspareunia. And then this is strictly a physical diagnosis. So this means that someone is having physical pain with intercourse.
Okay. And what do we know about what types of things cause dyspareunia?
Yeah, so really good question there. So oftentimes there are a few different kind of factors, and we'll kind of lump things into environmental, hormonal, or physical causes. So of course, as you would probably guess, oftentimes it's a combination of all of these things. So environmental factors, of course, can be, relational issues, anything that's going on between you and your partner. Hormonal issues is when we typically see, prenatal or postpartum hormonal shifts, or perimenopausal or postmenopausal shifts that can cause a change in the tissue quality that affect things like lubrication. They can affect tissue elasticity and can create some pain with intercourse. And then physical causes, typically what we're referring to there is we're actually looking at the vaginal canal creating pain when that vaginal canal is penetrated. So we're looking at, this can be pain from a lack of blood flow. It can be pain from a lack of lubrication. It can be pain from, a closing down of the vaginal canal. Any of those physical factors would actually cause pain with intercourse.
Okay. So, and my understanding is that can happen both at the entry of the vaginal canal, or pain can happen maybe with deeper, maybe considered deeper thrusting or things.
Yeah, absolutely. Yeah, so pelvic physical therapists tend to kind of lump dyspareunia or painful intercourse into kind of two different categories. So we'll have entry or introital dyspareunia, which means typically just a little bit of, or it can be a little bit or a lot of pain upon initial penetration. So as soon as the partner attempts to penetrate, there can be pain at the opening, and it may or may not resolve as you kind of get going. And with deeper penetration, what we see is maybe we're okay right at the beginning, but as the partner penetrates a little bit deeper, we have more pain. And oftentimes women can have both.
Okay. And so in regard, you mentioned like you might be having problems with your partner as a reason, like an environmental reason. Why would that cause pain during sex if you're having some kind of relational issue? Or
Absolutely. Great question. $1 million question, right? So that can be affected. So we all have kind of a natural, what we call a sexual response cycle. And as we go through the sexual response cycle, there are different physiological processes that take place that can help us to kind of facilitate intercourse. And a lot of times, if there are relational issues with the partner, what we find is that it may be a little bit harder to kind of move through the stages of sexual response. So we may have issue with getting blood flow through to the genitals. We may have issues with lubrication, and those things in turn can create a physical cause for painful intercourse. But of course, the root cause there is more environmental in nature.
So meaning that if you're upset or having conflict with your partner, your body may not be as physiologically aroused as it would be otherwise if you were more relaxed or in a space more that's pleasure centric. Is that what you're kind of getting at?
Yeah, absolutely. Our body holds stress, our body holds memories and can hold kind of tension. So just like we hold tension in our shoulders, right? If we're irritated or stressed, we can actually hold tension within our pelvic floor muscles. And what happens when our pelvic floor muscles tighten up is they can actually close down that vaginal opening.
Okay. And this happens involuntarily. Like you don't have a lot of control over this, right? It's not like you can say, vagina, it is now time to open up, or lubrication, please come forth.
Yeah, good question. Really good question. So, of course, there are certain aspects of the sexual response cycle that we don't have control over. Those are our nervous system controlling those things. So you're right. It's not like I say, okay, I'm now going to lubricate and then it begins. The interesting thing when we're talking about holding tension in muscles, though, is that is something that we can make changes in. And that's what a lot of what we do in pelvic physical therapy is actually bringing awareness to the tension being held in the muscles and training for letting go of that tension, lengthening the muscle out. We call it down training, but that is kind of the piece of things that can be affected.
Okay. So you've mentioned pelvic floor several times now.
Yes.
Most people kind of have a general idea of what the pelvic
floor
is.
Here.
Maybe not.
Yeah.
So why don't we talk a little bit about what is the pelvic floor? I think sometimes a lot of people think, oh, this is about Kegel exercises or something along those lines.
Yeah.
What's the pelvic floor? How do we understand what we're talking about here?
Absolutely. I can't believe we've been talking for 10 minutes and haven't talked about the pelvic floor yet. So your pelvic floor muscles, they're a group of muscles. They sit at the base of your pelvis. They attach from the pubic bone back to the tailbone. What I always tell people, if you were to sit on a saddle, everything underneath that, everything that the saddle touches underneath that is where your pelvic floor muscles are. So they kind of form a hammock or a sling underneath our body. They have a few different really important functions. So they're involved in bowel and bladder function. They're involved in sexual function. They do help with orgasm. They also help to create some erection of tissue that helps out with lubrication. They help to keep our pelvic organs internal in our body where they belong. And then they help to support and stabilize our lower back along with our transverse abdominis. So for women, within our pelvic floor muscles, we actually have the pelvic floor muscles give support and structure to both our rectal cavity and our vaginal cavity. So the vagina is supported by the pelvic floor muscles. So the pelvic floor muscles, and we'll talk a lot today about pelvic floor spasm or pelvic floor tightening up. When the pelvic floor tightens up, what you want to imagine is that it just kind of closes down that vaginal canal and makes it really difficult for anything to get in.
Okay. And men have pelvic floor muscles too. This is not just a
They
female
do.
version. And this actually helps with their, like you're saying, their rectal control and also their sexuality as well.
Absolutely. Yeah. And bladder control as well.
Correct. Okay. So one time when you were talking to us in one of these classes, you made the kind of comparison of, when we're tense, most of us understand that we carry a lot of that tension kind of like in our shoulders or our neck, a lot of times you see people massaging the neck and it's like, oh, that feels so good. Or I didn't realize I was tight in that spot or,
yeah,
we kind of scrunch up, right? But you made a comparison to what our pelvic floor does and that it's actually much more intense.
Yeah. Yeah, so there have actually been studies done where participants were shown stressful or threatening visual stimuli, and the researchers measured activation in their upper trapezius muscle, so that shoulder muscle that we tend to see kind of tighten up and make our shoulders rise. And then they also measured activation in the pelvic floor muscles. And what they found is that there was as much or more of a tonic or a tightening contraction of the pelvic floor muscles as there was in the upper trapezius. So a lot of people, when you start talking about, stress and its effect on the shoulders and how you'll notice a lot of tension here, everyone knows what you're talking about when you start talking about that. But there's actually just as much effect, if not more, at the pelvic floor muscles.
Okay. So yeah, you're tightening up, you're closing up, you're kind of coming into yourself, which isn't very conducive to the flow, the energy that we usually want to be experiencing when we're having sex, right?
Yeah, well, and any time that a muscle tightens up, we want to think about, again, going back to that sexual response cycle, one really important piece of that is blood flow getting through the pelvic floor muscles and to the genitals, right? That helps a lot with arousal. And so when the pelvic floor muscles are very, very tight, it can make it harder for blood flow to get through as well.
Okay, right. So let's go through the sexual response cycle really quickly. And I'm using your notes, by the way, to ask some of these questions.
Perfect.
You have the heart rate increases, you have blood flow going to genitals. So you have a swelling for female bodies, labia, clitoris, the vaginal wall even, correct? If I understand correctly, all the blood is flowing through there. And all of that also helps on breasts as well, breast engorgement, nipple engorgement, and vaginal lubrication is all part of that as well. Yes?
Yep.
And at male bodies, it's erection, scrotum tightens, and penis also will secrete some lubricating fluid. Most people usually call that pre-cum or something along those lines. So so that's kind of what's supposed to be happening for everybody when you're aroused, when you're desirous to have sexual encounters. But if you're saying your muscles are super tight and you're holding a lot of stress or anxiety in those pelvic floor muscles, that can interfere with the amount of blood flow that gets to all of those areas. Yes?
Absolutely. Yep.
Okay. And so you're saying too that, we can learn how to, like, if you point out to me, oh, you're carrying a lot of tension in your shoulders, I might be like this.
As we're both adjusting.
Oh, maybe I can lower. Maybe I can lower my shoulders or roll them a little bit. So there are a few things I can do to help those shoulders relax or expand. So is this a good time to talk about kind of what a pelvic floor therapist does and how you help maybe manipulate some of that shift and tension?
Yeah, absolutely. So a pelvic floor physical therapist, is a physical therapist that is specially trained to treat anything related to pelvic floor muscles. So any kind of bowel, bladder dysfunction, any kind of pelvic pain, as well as painful intercourse. So when we're looking at painful intercourse, if we are concerned that the pelvic floor muscles are too tight, oftentimes what we will do is we will take patients through what is called down training. So it's actually where we teach people how to relax their pelvic floor muscles. So more often than not, what your pelvic floor physical therapist will want to do is they will want to do, if you're having painful sex, they will want to do an internal vaginal examination. It's typically a single digit exam. We insert a single gloved lubricated finger, and we basically, we talk about the pelvic floor muscles like it's one big muscle, but it's actually a network of 12 different muscles within the pelvis. It's a really important group. And so the pelvic floor physical therapist will actually go through each muscle and identify tightness. And then what we begin to do is we can treat with acupressure techniques or soft tissue mobilization or myofascial release, actually getting those muscles to calm down, to loosen up. Just like if you had, chronic headaches and you went in to see a physical therapist, they would work on your neck, they would find points of tension at the base of your skull and kind of hold their pressure there until they feel it release. It's the exact same idea. So we're going to go through the pelvic floor muscles, create release in these different areas, wait until we can actually feel blood flow coming back through the muscles. And so that's kind of the first step where we're actually manually loosening up the muscles. And then step 2 of down training is then teaching you how to keep your new range of motion. So oftentimes what we're doing is we're kind of bringing that awareness of, try to imagine the vagina as a circle opening wider. So trying to kind of train people to let go of those muscles a little bit. And then we'll even utilize diaphragmatic breathing. So one hand on the chest, one hand on the belly, taking nice deep breaths in, making sure that the hand on the belly rises and not the hand on the chest. And what the reason that we use that is because every muscle in the body has an antagonist muscle. So for the pelvic floor muscles, its antagonist is your diaphragm. So when you're doing diaphragmatic breathing and forcing your diaphragm to fire and on the inhale, it actually forces your pelvic floor to drop and relax. And it creates that lengthening of the muscle that we're looking for. So we use that a lot as far as teaching people how to turn those muscles off.
Right, which gets me back to kind of the Kegel dilemma. I think that everybody
Yes.
thinks that they should be doing Kegels. Is that true?
Yes, no, my disclaimer for Kegels is they're not for everyone. So, oftentimes, sometimes people will say, I've been having painful sex and I Googled it. And so I started all these Kegel exercises and it's only making things worse. Remember that if you are having painful sex because of tight pelvic floor muscles and you start doing Kegels, you are now strengthening a muscle that is already too tight. So that would be like if let's say I lost range of motion in my elbow here because my bicep was so tight, that would be like me saying, okay, well, I'm going to try bicep curls and see if it gets better. All I'm doing is making the problem worse. So Kegels are definitely not for everyone. They come with a disclaimer. You really only want to be doing Kegels in patients that it's indicated for.
Okay. So that's really important because I do think that just seems like everybody should be doing them all the time. That's not,
right.
That's not the recommended.
Right. And there's all the different eggs and weights and everything else out there. And not the recommendation.
Right. Do you want to talk about that a little bit? The yoni eggs seem to be a really big deal these days. Is that touching with a 10-foot pole or not?
Yeah, really good question. We get this a lot in our practice too. So if we're talking about a pelvic pain condition like painful intercourse, again, not something I would prescribe for a patient. I've had patients ask about them. If you have issues with pelvic floor tightness, again, it's only going to make the situation worse because now you're putting a weight into the vagina that's now going to cue your pelvic floor to be on at all times, right? And your pelvic floor is part of your core muscle group. So it has some anticipatory functions to it. As you're up, moving around, as I'm shifting while I'm talking to you, my pelvic floor responds to that. And so at no point in time do I want my pelvic floor just on and held that way, right? And so where the egg can be problematic, especially in populations that do have issues with pain, then it's creating way more tension than you could possibly need in that muscle group. And similarly, even if you do have a condition that, maybe you are a good candidate for strengthening, there's some weakness in the pelvic floor muscles. A lot of the times those products are okay short term, but to say, put a vaginal weight in and go about your day, doing laundry and cleaning the house and running the grocery store and running all your errands. Again, that's the equivalent of me walking around with a dumbbell in my hand all day long because I want to strengthen my bicep. It's just not how the muscle is intended to be used.
And can cause some other problems, I guess.
Exactly. Yeah. Right. Yeah. It can cause an injury.
Okay. Going back to the sexual arousal cycle or the sexual response cycle, we talked about, kind of that arousal point and how if you're tight, it can interfere with lubrication and blood flow. At the same time, it can also interfere with orgasm and resolution. Is that correct as well?
Yeah, absolutely. So, in both men and women, there does need to be some pelvic floor awareness and some level of strength for orgasm. And so, what we know with pelvic floor tightness, so a lot of times, if we're talking about needing pelvic floor strength, a lot of times people will say, well, the muscle's tight, so it has to be strong, right? But muscles have, an appropriate length tension relationship, meaning that each muscle kind of functions best when you're starting from your resting length. So, again, using my bicep as an example, when I have full range of motion, my bicep has its normal strength. But if I have a shortened range of motion, now this is all that my elbow can straighten out. If I go to bring my arm up towards my face, I've lost a lot of range of motion there. And so I have a strength issue because my muscles are so tight. So muscles can be tight and weak as well. And so that's when you can see some issues as far as orgasm, because again, you do need strength of the pelvic floor muscles for orgasm.
Okay. So this would maybe lead to not being able to achieve orgasm or less maybe intense orgasms.
Potentially, yeah. We have heard that from our patients where, they're having issues with pain with intercourse, and then over time they're finding that it's more and more difficult to orgasm.
Okay. How
Mhm.
often would you say, as a sex therapist myself, I'm oftentimes surprised. Well, I shouldn't say surprised. We should not be surprised at the lack of sexual education. 'Cause
Right.
quite
Never.
frankly, there just haven't been many resources for good sexual education. But I am sometimes, surprised in the sense that people don't understand how important lubrication is and also
Mhm.
don't necessarily understand the female, especially the female response cycle in the sense of it can take a little longer, or it's really important to make sure that the female body is sufficiently aroused for penetration to not hurt, right? So sometimes
Absolutely.
it isn't so much that there's a medical condition, it's just that the person hasn't been sufficiently aroused or turned on for sex not to be painful. How often do you see that versus no, there really is something a little bit more here that we probably need to look into? So if somebody's like, well, I am having painful sex, at what point should they say, well, I've tried the lube or I've tried the arousal thing, maybe now there's something else going on?
Yeah, absolutely. So that's a really good question. So, to be honest, a lot of that we do work closely with sex therapists. So, you guys are my best friend. And so, certainly, if we're at all concerned that there's something more than physical going on or something, at this point we've resolved the physical and yet the pain continues, then, we'll kind of lightly talk about, the importance of foreplay, importance of good lubrication, making sure an additional lubricant is needed, that it's a good high quality lubricant that sticks around. But then also too, we are never afraid to refer out to sex therapy and get you guys involved just as far as, possibly working with the patient and their partner as far as foreplay goes.
Right, right. And you mentioned, it's couple conflict is obviously, if I'm grumpy with my
Mhm.
partner, I might have some issues getting aroused. At the same time, I can be
Right.
super pretty good with my partner, want to have sex, want to feel arousal, and there may be some other maybe psychological issues also kind of causing that
Hmm.
tension. I know,
Absolutely.
yeah, some of the things that maybe we've talked about is fear or avoidance or maybe
Hmm.
sexual
Yeah.
trauma. I mean, can you talk a little bit about that interplay?
Yeah. Yeah, absolutely. So especially in someone, and we see this a lot in our practice when someone has a history of painful intercourse or maybe a history of sexual trauma, as you mentioned, our bodies remember pain, our bodies remember that traumatic experience, and it holds on to it. So even though we've treated the muscle spasm, we've treated the physical causes of this painful intercourse, what can happen is when you go to have intercourse, and even though we're sufficiently aroused, partner wants to be there, what can happen is there's this anticipatory kind of tightening and spasming of the pelvic floor muscles, because our muscles, part of their function is actually to protect our body. So if I get up from this couch right now and I sprain my ankle, all the muscles in the area are going to tighten up and try and protect my ankle because that's part of their function. So the pelvic floor muscle, if you are anticipating any sort of pelvic pain or vaginal pain, the pelvic floor muscles can tighten up to try and protect the area, but that actually closes down the vaginal opening and then creates pain. So we kind of get into this whole pain spasm cycle where there have been, a series of painful sexual experiences that can be hard to kind of backtrack out of, even though they're making good physical progress in physical therapy. So a lot of times with these patients, we have them working with vaginal dilators on their own. And what's really nice about that is that they often come in kind of graduated sizes. And so the patient kind of has that confidence of, okay, when I'm on my own, when I'm fully in control of the situation, I can insert, X size dilator that is similar to my partner's size, and it's not painful. So in theory, it just kind of gives that little extra confidence boost going into attempting intercourse with a partner of, okay, this should be pain-free.
Right. Perfect. Let's talk about babies.
Yes.
So postnatal in particular, right? So maybe somebody has had a fairly pain-free experience with sexuality. Now they're having their first or second or third child and having some painful intercourse afterwards. What are some of the things that may be contributing to that?
Yeah, really good question. So a lot of changes occur in the pelvis during pregnancy and delivery. So just looking at pregnancy, we have some hormonal shifts that can definitely affect the vaginal tissue. We also have, as the baby continues to grow, our center of mass shifts forward. This increases the tilt at our pelvis, which puts our pelvic floor at a position of increased demand and can cause some tightening of the pelvic floor muscles. So that in and of itself can cause painful intercourse. And then when we start looking at the delivery, if we have a vaginal delivery, we can have perineal tearing, maybe an episiotomy, or just muscle muscle and nerve damage from the delivery itself. All those things can contribute to painful intercourse. We've had an episiotomy or a perineal tear if it was stitched. Sometimes as that scar tissue grows in, scar tissue doesn't have the same property as normal tissue. It doesn't like to stretch the way that normal tissue does. And so that can definitely create some pain with intercourse. And then oftentimes, I'll hear people say, I had a C-section. How am I having painful sex? I thought I was out of the woods with this stuff. We know that with C-sections, a lot of times because your abdominal muscles are kind of out of commission for about 6 weeks, what happens again, as I mentioned, kind of at the top of all this, your pelvic floor muscles co-contract with your transverse abdominis. Our body, the human body, is amazing in that it can always find a compensatory strategy to work around injuries. So sometimes following a C-section, what we find is that women, as they're caring for their newborn, they become over-reliant on the pelvic floor muscles, start overusing them, and then they tighten up, and we can have issues with urinary incontinence and painful intercourse, even though there wasn't a vaginal delivery.
Oh, that was my experience, Christine. And can I
Yeah.
just tell you, I was like, first of all, shocked.
Yes, it can be really shocking for women.
My vagina. I thought, out of all the things of a C-section, I thought at least my vagina is intact, right?
Exactly. No, it's really surprising for women when it happens.
Yeah, and I was really angry about that because nobody had even considered to educate me on that, on that possibility.
Right.
So here I am, all excited, 6 weeks in, woohoo! And then
Yeah,
not so exciting. So that was an unfortunate surprise. So I think it's good for women not to expect pain, but if it does happen, that it's not necessarily abnormal. And that makes a lot of sense that we are still using a lot of those muscles, whether the baby comes from the tummy or the vagina, it doesn't really matter.
Exactly. Yeah.
Okay, so let's move to some other quote unquote big names that, are thrown around and sometimes are hard to know the difference. Like we mentioned dyspareunia, that's kind of an umbrella term for painful sex. And then maybe under that, there can be some more specific terms that have to do with more specific diagnoses. One of them is vaginismus. So can you talk a little bit about what is vaginismus and how does that have its own kind of list of diagnostic criteria per se?
Yeah, absolutely. So vaginismus is, by definition, it is a painful spasm of the pelvic floor muscles that kind of closes down the vaginal opening, which sounds a lot like what we've been talking about, right? But one of the kind of key hallmarks with vaginismus, where it's not just that the pelvic floor muscles are a little bit tight, it's an involuntary spasm of the pelvic floor muscles that makes it essentially impossible for women to use tampons, to have pelvic exams, to have even digital penetration. That it's that severe level of pelvic floor muscle spasm that essentially just completely closes down the vaginal opening. We always kind of talk about, I think, Natasha, when I speak with the students with you and Dr. Bueller, one of the things that we want to be really careful of is not calling every case of painful intercourse vaginismus. Of course, by nature of what vaginismus is, people with vaginismus will have painful intercourse, but just because someone has painful intercourse does not necessarily mean that they've got full-blown vaginismus.
Right. Yeah. And that's a really important distinction because things are treated differently too. So, and so for some people,
Absolutely.
vaginismus is, I mean, it's a fairly common thing to see with people who maybe have never had intercourse before, maybe are afraid of intercourse. So we see that type of presentation. But there is onset that can happen after you've had sex too, correct?
Absolutely. Yeah, absolutely. It can onset after years of pain-free sex.
Right. Okay. And the other term that I want to make sure we talked about is vulvodynia. So how would you refer to vulvodynia being about?
Yeah, really good question. So vulvodynia is kind of a generalized term for any pain on the external genitalia. So there's two different types of vulvodynia. And the first is generalized vulvodynia. And that again just refers to any pain anywhere on the vulva, anywhere on the external genitals. It may or may not be made worse by touch or pressure. And then the second type of vulvodynia is provoked vestibulodynia. And that is pain specific. It's still the external genitalia, but it's pain specific to the vestibule or right at the vaginal opening. And typically with vestibulodynia, we do see where it's made worse by touch or pressure. So oftentimes tight pants, too tight fitting underwear, sitting on a hard surface, any kind of touch or pressure is interpreted as pain.
Okay. And then what are some of the things that might be going on here?
Yeah, so there may be some type of allergic reaction with vulvodynia. There may be some nerve pathways involved. Could be, there's potential autoimmune links to this as well. But oftentimes what we do see is because of this chronic pain or because of this kind of persistent pain in the genitals, pelvic floor muscles tighten up again, trying to protect the area. And then that can kind of exacerbate issues with painful intercourse. Pelvic pain can actually make the pain worse because of the tightness in the pelvic floor muscles. So often we see pelvic floor tightness as kind of a secondary piece of vulvodynia.
Okay. So that would mean having to go in and see somebody about possible either allergies or rash or something that's going on in the dermatological kind of part of this.
Possibly, yeah, you would want to rule out any kind of like irritation that might be causing it. It can kind of come about on its own as well. But, I've certainly seen plenty of cases where it's an allergic reaction to something. And oftentimes these patients do well with some sort of topical intervention as well from their doctor.
Okay. Do you want to talk a little bit about what the pudendal nerve is?
I would love to. Yes. So the pudendal nerve is a nerve that passes kind of through the pelvis, kind of dives right in between two pelvic floor muscles. And so oftentimes what can happen with this nerve is it can actually get entrapped as it's going through your pelvis and can cause issues with burning, pain with sitting, pelvic pain, painful intercourse. And I always kind of, when I talk to patients about it, I always kind of explain it's kind of like an internal sciatica. So, looking at the sciatic nerve, sciatica is irritation of the sciatic nerve as it passes underneath the piriformis muscle. So same idea with the pudendal nerve. It's actually irritation of the pudendal nerve as it passes through the pelvic floor muscles. And what can happen there too is, so the nerve is creating pain on its own because it's irritated, right? And when nerves are irritated, they're painful. That causes kind of spasming and locking down of the pelvic floor muscles, which makes the nerve pain worse, which makes the muscle spasm worse. So we get caught in this kind of pain spasm cycle.
Mm. And what kinds of things can be causing problems for the pudendal nerve?
Typically, we do see some component of pelvic floor dysfunction. So the pelvic floor muscle is actually locking down and kind of creating that pain there.
Like pinching it in some way.
You got it.
Okay.
Mm-hmm.
Okay. All right. Next big word, interstitial cystitis. Takes me say that 7 times.
Yeah, right? Yes.
So this is oftentimes having to do more with painful bladder syndrome, painful urination. Is that correct?
Yeah, so typically with interstitial cystitis, it's actually an irritation of the inner lining of the bladder. So what we see is issues with frequency, urgency, suprapubic pain or pain right above the pubic bone, and kind of this ongoing kind of burning, feels a little bit like you have a UTI component to it.
And so how are you supposed to know that this isn't a UTI? I mean, I think that's what most people assume. And or one thing that you shared with us, which I was like, ding, ding, every now and then you say things and it sticks with me. I'm like, is that people oftentimes will say, well, I've got a small bladder. And you make
Yes,
a
yes, yes,
point
yes.
of like, everybody has the same size bladder. That's not a
Yes.
thing. So can you tell me more about that?
Yeah, absolutely. So I think in context, when we talk about that, we talk about patients who have interstitial cystitis. These patients are 10 times more likely to have had bladder issues as a child. So oftentimes clinically, what we see is these are the people that say, I've always had a really tiny bladder. My family gives me a hard time. And bladders, the point that I always make is that bladders come in a pretty standard size and kind of standard capacity. So ideally, we want to be able to go 2 to 4 hours during the day between urinating. And we really only want to be up once per night to urinate. So any more than that, we would categorize as increased urinary frequency. And so what we see with interstitial cystitis is we have seen in cases where it can be, much, much more frequent than that, feeling like they need to go to the restroom every 15 minutes. When that urge is present, it's I got to go to the bathroom right this second kind of urge. It's not just kind of that low level, oh, I could find a bathroom.
Okay. And this tends to go underdiagnosed because, kind of like you said, people think they have a UTI. Is that correct?
Yeah, looks a lot like a UTI. So we have had patients who say, I had my urine culture, it was negative, but I could have sworn I had a UTI. I was really surprised. We do hear that from our patients. Mm-hmm.
Okay. And how do people get diagnosed correctly then? What's the difference between having somebody say, well, go get treated for UTI versus understanding what they actually have?
Yeah, that's what I was going to say. I was going to make the comment that we don't see a ton of that here because we have so many good urologists and urogynecologists in the area that are well aware of what interstitial cystitis is and kind of know the differences. And so, yeah, it would be a urologist or a urogynecologist that would be the best person to see for that.
Okay. So if you have a consistent problem with this and you haven't gotten much relief, maybe instead of seeing a general practitioner or a gynecologist, see a urogynecologist.
Absolutely. Yeah.
Female and a urologist if you're male. Okay.
Absolutely. Yeah.
All right. So endometriosis, that's something that a lot of people talk about and I think got more attention in the last 20 years than some of these other things. But can you talk about what endometriosis is?
Yeah, absolutely. So endometriosis is an overgrowth of the inner lining or the endometrium of the uterus. So in patients with endometriosis, they produce too much of the endometrial lining and it then gets laid down in other parts of the body, like on the bladder or the bowel or, even up at the diaphragm. And when that endometrial tissue is anywhere that's not inside of the uterus, it actually kind of hardens and becomes scar tissue and can create pain in the areas where it is, can create issues with mobility. A lot of times with patients with endometriosis, we see kind of like a generalized immobility of their pelvic structures. So it can lead to a lot of just kind of stiffness and pain within lumbopelvic and really thoracolumbar bases.
Which can lead to painful sex as well, especially with maybe deeper penetration.
Absolutely. Yeah. So we oftentimes do see pain with deeper penetration with endometriosis. And a lot of that is coming from, as we have deeper penetration in a healthy pelvis, the pelvic organs kind of shift out of the way. And our pelvic organs, all of our organs are meant to be able to kind of move within our body. If I take a nice deep breath in, my diaphragm descends, my pelvic floor drops, and all of my organs kind of shift down a little bit. Organs should be able to move a little bit within our body. And what we see with endometriosis is that those organs just don't move as well. And so when we have deeper penetration, nothing's kind of getting out of the way. And so it can create pain.
Okay. And treatments for endometriosis are typically what?
So pelvic floor physical therapy can be really, really helpful in terms of managing endometriosis pain. We can get patients on a really great home program as far as kind of keeping that mobility, managing flares. Diet can be really, really important with endometriosis. If there are any specific dietary kind of irritants that seem to increase inflammation for that patient, it's important to manage those. And then, of course, being under the care of a gynecologist that is skilled in working with endometriosis is important as well.
Okay. All right. And so before we get too much further, because I definitely want to cover postmenopause a little bit, there are a few things that people should be thinking about in regards to just hip joint issues, maybe tailbone, like a tailbone injury. So kind of maybe more structural things that have happened in their lives.
Yeah. more of kind of the musculoskeletal stuff. So like we mentioned, the pelvic floor muscles all attach to that tailbone. So if you're a former gymnast or cheerleader or snowboarder or something where you have these kind of recurrent falls on the tailbone, what can happen is as there's a little bit of instability where the tailbone meets the sacrum, there can be some instability there, and your pelvic floor muscles can kind of spasm to try and protect that area. And that can create some pain with intercourse as well. And then your pelvic floor muscles. So everyone knows we have our shoulders are a ball and socket joint, and we have a rotator cuff around that. Our hip is actually a ball and socket joint as well, and we have a rotator cuff around the hip as well. One of our hip rotator cuff muscles, called the obturator internus, actually runs congruently with our pelvic floor muscles. So if there's an issue with the hip joint surface integrity, so if we're looking at something like arthritis or a labral tear or femoral acetabular impingement, what can happen is the hip rotator cuff muscles all kind of tighten up to try and protect that hip and kind of lock down that range of motion a little bit to protect it. And because that obturator internus is part of the hip muscle group, but also runs congruently with the pelvic floor, what we'll see is that the pelvic floor will then kind of start to go into spasm along with everything else. So I've had a number of cases of patients that I'm working with that have a new onset of painful intercourse. And then in talking to them, you find out that they're bone on bone in their hip and waiting on their hip replacement. And oftentimes, the pelvic floor spasm still needs to be managed, but that underlying why is the pelvic floor spasming comes from the hip. So anytime that you're dealing with pelvic pain, pelvic spasm, it's really, really important to kind of dig a little bit deeper, find the why of where is that spasm coming from, and not just treating the spasm.
Right. Yeah. Might need a hip replacement or something along those lines.
We don't recommend that for everyone, but yes.
Right. For sure. Okay. And post-menopause then, what are we dealing with in regards to, I know this is again a hormonal issue, yet what kinds of things are happening post-menopause that might show up in painful sex, pelvic floor dysfunction?
Yeah, absolutely. So one of the shifts that happens with menopause is a depletion of estrogen, and the vaginal tissue, especially right at the opening, is very, very rich in estrogen receptors. So as our estrogen levels kind of drop and level off, what we can see is that vaginal tissue kind of thins, it loses elasticity, it can lose lubrication, kind of dry out a little bit. So all of those things can kind of create this perfect storm for painful intercourse because we've lost elasticity. The tissue doesn't like to stretch anymore. It's really, really thin, so it's really irritable. And then we have, decreased lubrication in the area, so it can really create a lot of difficulty with painful intercourse.
Right. Okay. So that's something to be thinking about in regards to kind of menopausal, not treatment, because menopause isn't a disease, but menopause management, right?
Yeah.
And what kinds of things are there that people can do about those kinds of things?
Yeah, so a lot of times in terms of looking at kind of, like you said, menopause isn't a disease that we want to treat. So just kind of looking at different natural, non-hormonal ways to address it. We talk to our patients a lot about wanting to use coconut oil or emu oil kind of right at the vaginal opening. And I'll tell patients to use that daily. I always say, just as we age, the skin around our eyes become more sensitive and we start using eye cream and kind of giving it a little bit more kind of moisture and attention. It's the exact same thing with the skin at our vaginal opening. You just want that little bit of kind of extra moisture to help kind of support it. And that can really make a big difference. So the two recommendations that I typically make in terms of things that you can buy at the grocery store tomorrow would be coconut oil or emu oil.
Okay. Awesome. All right. So moving on to maybe like myths that I hear sometimes.
Yes, my favorite.
You could just say, yeah, there's something to that, or no, there's not anything to that. So,
oh my gosh, I love it.
So I only have two that I can think of. Maybe I'll try to think of more. But one that I hear a lot is my partner's just too big. So in other words, heterosexual female, male partner, and his penis is just too big. And that's why sex hurts.
Yeah, absolutely. So there is something to it in the sense that, if you have a complete kind of mismatch of equipment, maybe a little bit of a struggle. But remember, the pelvic floor muscles give support and structure to the vagina, and they are muscles by definition. So muscles, everyone knows, they shorten and they contract, but muscles also lengthen and stretch out. So the pelvic floor muscles should be able to stretch to accommodate
most penis sizes, correct?
Yes, most penis sizes.
Right. So when you say there's some mismatch, I mean, how typical is that really, that there would be a huge mismatch? Because I think I hear this much more often than I think is statistically relevant.
Is yes, absolutely. You know, I'm trying to think of a case where there was a true mismatch, and in 10 years of clinical practice, I can't think of one.
Right,
Yeah.
right. Okay.
Because then you can supplement with things like lubrication and other things that can kind of help to facilitate the process.
Right. Well, and I think of width of a penis, right? Or is it width? Yeah, length, width.
Yeah.
I'm not very good at math. So with when you think about a vagina really being capable of making room for a baby's head, I
Exactly.
don't know that I've heard of a penis that is that, wide. So your
Exactly.
vagina has the capacity, right, to stretch quite a ways.
Absolutely.
Maybe in length though, however, is that potentially an issue as far as hitting, like, is it the cervix that you'd hit that
Yeah,
might be?
certainly could be more of an issue, but again, you can alter that positionally, just to allow for maybe not as deep of penetration. But yeah, the width not going to be as much of a concern because, as you said, from an anatomical standpoint, female pelvises were designed to stretch enough to allow a baby's head out. So width not as much of a concern. Length, a little bit more validity to that, but still certainly some workarounds to it.
Okay. Myth number two that I'm aware of. So
Yes.
maybe not myth, but I hear a lot of people telling me, well, I think that my uterus is tilted, or I must have a weird angle to my vaginal cavity, and therefore that's what makes sex painful. In other words, they're saying there must be something structurally wrong in order to accommodate intercourse.
Yeah. So uterine retroversion would create pain with intercourse, but again, probably nowhere near as common in the general population as people express to you that they think that's what's going on. Oftentimes, when I hear people talk about, it feels like, like the left side just won't accommodate penetration, or they'll talk about feeling like there's something off with the shape or there's some kind of structural issue. What that really is there's a spasm in one of the pelvic floor muscles that's kind of creating this sensation of something being structurally off, but it really ultimately comes down to muscle spasm.
Okay. So even those things could be looked at from a pelvic floor therapist perspective and get a better idea.
Absolutely. Yeah.
Okay. Last thing I think I want to talk about, because I know I'm like, oh no, my time is running up. It's, anal sex, right? So you have
Mhm.
a lot of people who, both male bodies and female bodies, that enjoy anal sex or want to be able to accommodate anal sex. And of course, this is another way that you can have quote unquote painful sex. Some people might say,
Mhm.
well, of course it's going to be painful. This, the anus is not necessarily quote unquote meant for intercourse. And yet we know that anal stimulation and intercourse is very pleasurable for many people. So how does this tie into a pelvic floor possible issue?
Yeah, really good question. So, if there is, severe pain with anal intercourse, again, when we're talking about the anal canal, again, given support and structure by the pelvic floor muscles. So, if there is excessive tightness in the posterior fibers of the pelvic floor muscles, it would potentially create pain with any attempt to penetrate anally. So, absolutely, pelvic floor could potentially be involved. We also have our external anal sphincter, which we want to be careful not to stretch too much because that muscle is really important for maintaining fecal continence. So that's my only caveat with anal intercourse, is just being careful not to overstretch that external sphincter because we want to maintain the integrity there.
And lubrication being hugely important, correct?
Yes, lubrication is extremely important.
Mm-hmm.
Yeah, exactly. Yeah, because the anal cavity, like you said, doesn't naturally lubricate the way that the vagina does. We definitely need supplemental lubrication, and a good one.
Okay. All right. So given all that we've talked about, which is a whole lot, if you're
Yes.
listening to this, I recommend you listen to it again. I listen to Christine like twice a year and I still learn things every time because I'm like, so what would you say are maybe some of the hesitations or, reasons why maybe people feel like maybe they should come to see a PT, but don't do it? What's getting in
Yeah.
the way?
So I think probably the top two that I hear are, one, I'm afraid it's going to be really painful. So if you're talking to a woman that has, let's say, vaginismus, and they can't even insert a tampon without severe pain, the idea of voluntarily coming in 1 or 2 times a week for 45 minutes to an hour so that we can attempt to loosen up those muscles to allow penetration sounds like nothing short of torture to them. So one of the things that I always try to make really clear with patients is there will be a little bit of discomfort every time that I find a tender area, but at no point should this be painful. If we're talking about a 10 scale, 0 being I have no pain whatsoever, and 10 is, oh my gosh, get me to the emergency room, we should never really be going above a 2 or 3. So it's really, really pelvic, good pelvic floor physical therapists will really take their time with their patient and kind of do whatever their body allows. So if I've got a patient with severe pelvic floor spasm, maybe the first 4 visits, I'm only assessing and treating the superficial pelvic floor muscles because their body just won't allow anything else. And that's okay. You don't want to push past that because at that point you're creating more pain and trauma associated with penetration. So that's kind of the first piece, is this fear that it's going to be extremely painful. And I always tell people, a little bit of discomfort, yes, but should be no worse than, a momentary discomfort, and then should feel better as we start treating. So that's the first one. And then the other thing that I think keeps people from coming to pelvic floor PT that I tend to hear is just, it sounds weird to them. They're worried about it being super uncomfortable, not wanting to have to come in once a week for someone to do internal work on them. And what I always tell people is it sounds way worse than it is. When I first start telling you what I'm going to do for the physical exam, it sounds like it's going to be super, super invasive, but actually most, we don't use stirrups in the office. We have nice, comfy exam tables that are really more like a massage bed than a doctor's office table. We have cloth sheets. You can see my face the entire time. It's not like stirrups where I'm kind of down at the foot of the table yelling to you from under a sheet. I'm seated to your side. We can make eye contact at any time. You're in full control of the exam. And, if you're uncomfortable, you can say stop. Aside from the initial kind of visual exam of the area, you will see my face the entire time.
Yeah, that's really good, because it's one thing for me to go and give you my ankle for you to manipulate.
Right.
Another thing for me to go and give you my vagina for you to manipulate. So.
Exactly. Yeah. And I think a lot of times too, people, when they think about pelvic floor physical therapy, they think about like their annual pap smear and like you're going to be in stirrups and there's going to be, a speculum and all this stuff. And that's just not the case.
Yeah, good. Well, pelvic floor therapy is a fairly new profession. I mean, you haven't been around for very long. Isn't that the case?
Yeah, it's really been, I would say, in this area in the past, 15, 20 years, it's been really kind of gaining traction and becoming more mainstream. So it's been really exciting to kind of be a part of its growth. I work, as you mentioned, for Hoag Hospital, which is a well-known hospital in Orange County. And we have 2 locations. We have 9 physical therapists between our 2 locations. And we have, a multitude of other disciplines around us as well that really kind of differentiates us from other practices. We have, all these practitioners here under one roof, which has just been really, really exciting to kind of see the field grow and, see the need to continually bring more members onto our team because there are so many women out there that want help.
Yes. And to actually feel like there's hope, because I know not too long ago, a lot of times, a woman would get a pat on the back, like, well, try to relax, drink a glass of wine.
Yeah.
And
that is how it is.
Extremely frustrating, right? When you know that there's something going on with your body, and to be kind of it feels condescending or belittling to just kind of be told, well, it's kind of in your head. It wasn't that long ago that a lot of women were getting that type of treatment from their primary physicians, for sure.
No, it wasn't. And it wasn't that long ago that we would hear, that's how it is after you have a baby. Things are just different, or that's how it is as you age. Things just change. And to kind of know that that's not the case and to empower women to find answers is a very rewarding field to be in.
Absolutely. Well, and you said that you love sex therapists, but I'm telling you, I love pelvic floor therapists because before we were limited too. It's not, as a sex therapist, I'm not doing any type of physical exam. We might have been able to say, well, have you tried, dilators, but not really knowing if that was the accurate treatment or not, because that can be helpful in some cases and not helpful in others.
Yeah.
So I think that now, to have kind of that 3-tiered team, the sex therapist, the pelvic floor therapist, the gynecologist or your gynecologist, that's a very powerful team to many of these issues, and women in particular, and men too, are getting results that we've not seen before. So that's wonderful, very hopeful.
Yeah, absolutely. Yeah, it really does take a village. And, like you said, having kind of a team that's approaching this patient, I feel like that's how you really address that patient's needs and how you really treat the whole patient as opposed to just treating your specific. Of course, I stick, within my scope of practice, but knowing that the right people are in place taking care of the other issues, you can kind of rest easy that the whole patient's getting care and not just the physical, not just the mental.
Exactly. All
Mhm.
right. Anything I didn't ask that I should have? Anything that you're like, oh, I wish I could have said this or that, or
No, I mean, we could talk for 5 hours on pelvic floor dysfunction as far as I'm concerned, but I think we covered a lot.
okay, good. So, and I'll make sure and share your contact information and things of that nature in case anybody wants to know more about Hoag, in case you are in the Orange County area, or other ways that you could, if you have resources or whatever, that they could take advantage of that. And I'm just
Absolutely.
so grateful for your time. I'm grateful for Hoag and being willing to represent and have you represent. So I have heard
Yeah.
only good things about Hoag. So if you're lucky to be able to be in their vicinity, definitely take advantage.
Yeah, absolutely.
And,
Come visit us.
yeah, for sure. So thank you so much for your time. I really appreciate it.
Of course. Thank you for having me, Natasha.
All right, take care. Bye-bye.
Bye-bye.
There is a place where time slows to nature's pace, and there is space there to find yourself in her embrace. Some places should be left alone. No tishki say the so we can always go to the homeland of the heart. 10,000 years of our human history etched on her canyon walls, alongside Earth's mysteries. Some places should be left alone. No tishki shade so we can always go to the homeland of the heart, to the homeland of the heart. Deep in our cities, we sleep without her stars, yet still her presence sustains us from afar. Some places should be left alone. No tishki shade so we can always go to the homeland of the heart, to the homeland of the heart, to the homeland